Hello, Dr. Pinto. Open.
Hello, can you hear me?
Yeah. We really can't hear you.
Can you hear me well?
Yes, okay. Good morning, Dr. Pinto. It's good to see you, and unfortunately not physically this time. I'm wearing the official Luxor dress. Unlike the others, we are officially on the session. So I just came to greet you and thank you for joining us. And it was a great lecture yesterday, although recorded, but it was great. And I thank you again. You know, Dr. Fausto is actually an integral part of CardioLuxor, and I hope next year he will come to us physically. And I leave the mic to Dr. Gamila, who will lead the session. And thank you very much. I'm joining another meeting at the pool, okay?
Professor Pinto, how are you? I'm Gamila Nasr. I'm very happy, and we have, met you in CardioPrevent the year 2019, and we are very proud to have you in this big event, and a big welcome to you in CardioLuxor 2021, and we're very proud to have you with us. And thank you for your kind contribution with all the scientific activities of Egypt. Thank you very much.
Well, thank you so much. It's a real pleasure to be here. I'm sorry I cannot be there. I would love to be there, as I've been in the past. I want to thank my friend Dr. Trib, Adele. It's really been a long time friendship, and with you as well as with many friends from Egypt. So it's always a pleasure.
Maybe we'll be very happy to meet at CardioPrevent this year at November, and we'll be very happy to see you. And come back to Egypt, your second home country.
Thank you so much. Thank you.
We have to start the session, and actually, your kind presentation about, of course, we know about 3D echo, and I'm just, of course, I want your kind, opinion about should we do 3D echo as to replace the usual conventional 2D echo, or as a focused technique within would it replace the 2D echo? Do you think so? And we have the pleasure to start the session about the role of 3D echo in valvular heart disease.
Well, thank you so much again. And again, it's my pleasure and privilege to be here today. Again, I'm very sorry that unfortunately I cannot be there in the physical presence, but this is an alternative way. And for the moment, that's the way that we have to use. So I'm going to talk about the use of 3D echo in the setting of valvular heart disease. I will show you a couple of examples and basically showing you how 3D echo can actually help. I will not say replace, but to complement what we already can obtain with 2D echo and with all the different modalities that we already have with echocardiography. This is my hospital here in Lisbon. It's the largest hospital in my country, and it's also the medical school. And we're always delighted to welcome friends coming from all over the world, and certainly from Egypt. So how can we summarize the potential advantages of 3D echo? Well, first of all, heart is a 3D structure, of course. It can be and provide a more standardized procedure a more objective visualization, better accuracy of qualitative information, but very importantly, quantified variables of cardiac function in a more accurate and reliable way. And finally, it can be also useful to simulate surgical procedures because of all the detail of the anatomic details of the different components of the heart, and particularly the valves, as I will show you. Well, just a word on the implementation of 3D in the Echo Lab. It's very important that when you do that, you realize that particularly with some of the features and some of particularly the old algorithms that were used for 3D Echo were a bit time consuming. Now with some new developments, this is becoming more easy and more fast. It requires, of course, training in 3D echo analysis, and it's important, like for any other modality, that there will be proper training of the operators. The accuracy may vary with expertise. That's the reason why it's very important to have good training, and the reproducibility may also vary among individuals. And this is the reason why it have been developed some automated analysis programs, which have now been included in some of the brands and some of the machines that we currently use. So we want an accurate, we want a fast, we want it to have a minimal user interaction, and we want it to be reproducible. That's basically our goal when we look at 3D echo. This is an example, and this is already an example of the previous version of 3D echo, but where you can see it's a mitral valve prolapse, and where you can see the different cuts that you can have of the mitral valve with an anatomical observation of the valve, and that, of course, provides a lot of details that, again, can be more relevant, can be relevant for, particularly for some clinical instances, and can be also more detailed in the anatomic and morphological description of the valve, in terms of the location of the prolapse, in terms of presence of any other features that may help also in the decision making, particularly in valve disease, intervention or no intervention. This is an example of a patient with a flail anterior leaflet. You can see nicely here on the 3D echo. So this is a 2D. You can see a classical feature of mitral valve prolapse with the ruptured chordae. But what you can see with the 3D is actually the exact location. It's like you're being seated in the left atrium, looking down at the valve, and see exactly the location of the prolapse. And it's a very nice view, a very nice feature of an A2, which is flail. So this can actually be useful, particularly when discussing with the surgical team in terms of the type, even the type of surgery that can be done. Here we can see again a nice example where you see here the presence of a flail tissue, flail leaflet, very nice. You can even quantify the valve tissue that is prolapsing. Another important advantage of 3D is to provide also the occasion to do 3D measurements. And here the regurgitant orifice area can be measured, and there has been already evidence that it's more accurate, the measurement of the regurgitant orifice areas, which, as we know, is one of the parameters that we use for deciding if a patient has severe mitral regurgitation, for instance, or tricuspid regurgitation, and if the patient is already an indication for intervention. It can be also used 3D echo in combination, and this is a very important, and I will just show you some other examples of quantification of volumes. And again, here the use of 3D echo can be very advantageous in the objective quantification of left ventricular, left atrial, right ventricular, right atrial volumes. And it can also incorporate some of the information that we can get with strain and with strain rate, with myocardial deformation parameters like global longitudinal strain. All these can be incorporated into 3D images. Now, the use of echo can also be used for follow-up, assessing the presence of residual or recurrent mitral regurgitation after an intervention, either a surgical intervention or a percutaneous intervention, and also, very importantly, assess the presence of reverse left ventricular remodeling, which is, as we know, a good prognostic sign in patients that were intervened for, particularly for mitral valve disease. Let me show an example on the utility of 3D echo to assess volumes. This is an example of a 56-year-old male with Barlow's disease, mitral valve prolapse. He had a symptomatic severe mitral regurgitation. We can see here the follow-up, 6 months follow-up. From in these first 6 months, there was no significant difference. But then in 1 year after the first examination, we can see here, this is in January 2015. You can see that there is some mitral regurgitation here, thickened valve, and a myxomatous valve. And here you can see that now it looks like it is a little bit more severe, the mitral regurgitation. And then when you look at the volumes, you can see that there was no significant difference in the left atrial volume, but there was increase in end diastolic volume, increase in end systolic volume. But very importantly, there was an ejection fraction that went from 70% 1 year before to 58%. And 58%, as you know, is below 60%, which in a patient with severe mitral regurgitation is the threshold for indication for surgery or intervention. So the question is, can we trust, can we rely on these numbers, or do we have other ways to be more accurate? And this is where, again, the use of 3D echo can be useful. Here we see the use of these different measurements using this technology, which is also based on some algorithms that can allow also some automation of the measurements. And here you can see nicely in this case a very accurate way of assessing and measuring and quantifying volumes, which is very important, particularly when we have to decide based on some of these parameters. Of course, it's not the only thing that we look at, but to have reliable, accurate parameters is very important to make the right decision. And this is why to have a fast, easy, and reproducible tool is very important, such as this one. This is called the heart model. It's one of the quantification methods that can be used to assess left ventricular volumes. Excuse me. This is another example of an 85-year-old woman, severe tricuspid regurgitation. And here the use of 3D echo can also allow us to have a very objective assessment of the valve, of the ring, to measure, and this can be relevant when deciding and sizing the annulus, and particularly now that also evolving into intervention in the tricuspid valve. And also, it helped us to understand there is a pacemaker wire here, and this pacemaker wire on the 3D, we can see that it's actually interfering with one of the leaflets of the tricuspid valve, and this was actually probably one of the main mechanisms of the tricuspid regurgitation. So it was not only functional tricuspid regurgitation, but there was also the presence of this pacemaker wire that was interfering also with the mechanics of the tricuspid valve, being responsible also for the tricuspid regurgitation. And again, here we can see the measurement by using 3D methods, the objective assessment and measurement of the regurgent orifice area with 3D. It's also been used, and it's being used for valve intervention, for patient selection, to monitor the procedure, to detect complications, and also to follow up. This is an example of one of our patients doing a mitral clip. You can see here the use of 2D. In this case, we have the 2D transesophageal image going across the valve. You see here different images, and then locating and grasping the valve tissue to implant this. And here we can see the fluor image already with one, and this is the second mitral clip. You can see the probe here. And now we have a nice view with 3D. And this is really, I would say, a fantastic tool, particularly for the mitral clip, because it does provide real-time online assessment of our procedure and assessment of the success of the procedure. We can see nicely here this Alfieri-like mitral valve with the mitral clip here in the middle, this kind of two orifice in consequence of the clip of the presence of the mitral clip. This is another example. This is now, it's an aortic valve, a patient with aortic stenosis that was rejected for surgical replacement. See, very calcified valve. Here you have already the 3D image on a cross-sectional view. And here you can see nicely the passage of the valve, the implantation of the valve. You can see here nicely already the implanted valve, very well positioned. You can see the leaflets. This is another example of a perivalvular leak in a patient with a prosthetic mitral valve. You can see on the 2D image the periprosthetic leak. And here you see, again, a beautiful image on 3D, and where you can see now the wire across the perivalvular leak. Here you have the prosthetic valve. And you can see here now the implantation of a closure device for the prosthetic valve, for the perivalvular leak. And here you can see, the presence of basically no significant residual mitral leak through that valve leak. Let me just finish by showing you this new feature of 3D echo, which is using light absorption. And by using this spectral absorption, it produces more physically realistic images because of the different absorption qualities of the light of the different tissues, like the valve and the surrounding tissues. And they produce this type of images that I will be showing you. So this is a normal 3D echo, and then you can see now with the light absorption, very nice detail of the leaflets, of the ring, of even the tissues that compose. You can see nicely here this prosthetic valve, the struts of the valve, of the prosthesis, and very nice view with much more detail of the leaflets. A nice example here of a bicuspid valve. And here now you can see a nice example of a patient who had this perivalvular leak, and you will see now the result. You can see here the perivalvular leak with the leaflet, with the wire going across, and you can see now with the 3D image. In this case, they were implanted devices. And here you see the presence of this closing device. So in conclusion, I would say that 3D echo improves the assessment of valve morphology and function. New developments make 3D a valuable tool in the assessment of patients with valvular heart disease. And these highly performant software packages that we have now available not only improve the workflow in the laboratory by providing faster quantification, but also improve the inter-observer and retest reproducibility of the measurements. And with this, I finish. And again, thank you so much for the invitation, and thank you for being here with you today.
Professor Pinto, we are very grateful to your presentation, as usual, great. And of course, we're very lucky to have the president of the World Heart Federation to be sharing in CardioLuxor 2021. I have just a few questions about the 3D echo. One of the limitations of a 3D echo may be the frame rate. What's your comment upon that?
Yeah, it's correct that particularly the old versions, they had slow frame rate, and that could be a problem for instance, if you want to look at some features which we need higher frame rates. But this has been actually improving, and with the new softwares, the frame rate is increasing. I would say that for morphology, it's not a big issue, the frame rate, if you just look at anatomical features or morphological features of the different heart components. It could be an issue if we are dealing, for instance, with 3D strain, but that has been actually improved. And currently, with the new versions, there is already not as high as in the we do when we do 2D strain, but still going faster than it used to be. But I would say that for the main advantages of 3D echo, which is mostly for morphological assessment and functional assessment by quantifying volumes, I don't think it makes a big difference in terms of accuracy and in terms of reliability of the measurements and of the pictures that we receive.
Very good. Thank you very much. Another important questions that about the stitching artifacts, and maybe stitching artifacts is one of the limitations. It's very specific to 3D echo, especially in those having atrial fibrillation, irregular rhythm, and we encounter many patients with valvular heart disease with irregular rhythm. What's your comment upon that?
Yeah, that's I would say a limitation. That again, the new algorithms, as you know, there's been quite a lot of improvement, and some of the brands have been dedicating a lot of work to improve some of these issues that particularly were more relevant in the initial and the older versions. And that's why it's very important to have good training, because there are some tricks that you can use when obtaining the images and when selecting the images to improve that and to overcome some of the limitations. But like with 2D echo or even with M mode, we know, and the Doppler, tissue Doppler and myocardial deformation, we know that there are always some limitations. It's important that we know them, what are the limitations, and that we try to overcome those, not only by the improvement in the technology, but also by getting experience. And again, like for any technique, getting experience is very important to obtain better results.
Thank you very much, and my deepest thanks to the head of the president of the World Heart Federation, Professor Fausto Pinto, and our greetings to you in Portugal, and wishing to see you in the coming few months in Egypt. Thank you very much.
Thank you, Professor Pinto. Thank you.
Thank you so much. It was my pleasure.
Thank you.
All the best for you.
Thank you. Professor Luigi Badano.
Hi, Tarek, friends, I'm here.
Hi, Professor. I'm Dr. Tarek Aziz.
Sorry.
Hi. I am very happy to introduce you. You are #1 in the world in 3D echo, and you teach me 3D echo in Italy 10 years ago, and I attended to you your 3 international workshops for 3D echo after that, till before Corona. I am very happy to have you with us. Please, you can give us how to use 3D echo to evaluate tricuspid regurg in patients with EF. I know that you are very interested and like the tricuspid valve and the right ventricle. Please come.
Yeah, thank you very much for the kind invitation, and thank you to the scientific committee of CardioLuxor. This is really a pleasure, also because, as you said, you invited me to talk one of my favorite topics. I would try to share the screen. Sorry, I cannot.
Is there a problem?
No, I'm trying to share the screen as soon as I can. I cannot. Oh.
Luigi, please
Yes,
use
yeah.
the green button at the bottom of the screen.
Yeah. Can you see my screen now?
Yes.
Perfect. So thank you very much. So when we started from a current dogma in cardiology that is has been perpetuated for years, that functional tricuspid regurgitation is due only to the changes in the occurring in the right ventricular shape, size, and function. And as you see in this review made by Gilles Dreyfus in 2015, even in a patient with atrial fibrillation, the etiology of tricuspid regurgitation was linked to the altered right ventricular function. And this was perpetuated for years, and also in the recent, most recent guidelines from the European Society of Cardiology about the management of valvular disease is clearly stated that pathological tricuspid regurgitation is more often secondary due to the right ventricular dysfunction following pressure or volume overload in presence of structurally normal leaflets. So for so many years, we just simply followed the path without taking into account what we were seeing in the clinical practice. And in the clinical practice, we see cases that just don't fit with this dogma. And this is my first case. Is a relatively young woman. She has a class 3 thyroid goiter with the Graves' disease, and on May 2018, he developed a heart failure with worsening dyspnea on effort and peripheral edema. And at the clinical evaluation, she was found to have atrial fibrillation with a very high heart rate, 150, and also all the lab tests for arteriotoxicosis. When we performed the echocardiography, as you see, we have an enlarged right atrium and a coaptation gap at the level of the tricuspid leaflet, and we don't need any sophisticated quantitation to see that this tricuspid regurgitation is just severe, or as it's used today, massive or torrential. It's really almost no gradient between the ventricle and the atrium. 1 month later, she underwent a thyroidectomy, and after a while, she recovered spontaneously the sinus rhythm, and her clinical status improved, and she became asymptomatic. And when we have seen her just 2 months after the first echo recording, this was the echo. As you see now, there is almost a perfect coaptation of the tricuspid leaflet, and what was a torrential tricuspid regurgitation, just a mild one. And when we compare the echo performed in May 2018 and in May and in August 2018, you see that there was no much difference in the size of the right ventricle, just an improving in the function of the right ventricle as expected with the sinus rhythm. No major changes in pulmonary artery pressure, but what changes a lot was the right atrial volume that almost halved after the restoration of the sinus rhythm, followed by a dramatic change in the tricuspid annulus size and in the diameter of the vena contracta of the tricuspid regurgitant jet. And you say this is an atypical case, is a very specific clinical condition, but we have seen this also in a more regular patients with atrial fibrillation, as I am showing now. This is a 74-year-old woman with no cardiovascular risk factors. She had a first episode of persistent atrial fibrillation, and she was symptomatic for palpitations and dyspnea on efforts, and she came for pharmacological cardioversion to sinus rhythm when he arrived in emergency room. The echo that I'm going to show was recorded just the day after the cardioversion. And again, as we have seen before, there is an enlarged right atrium, no coaptation of the tricuspid leaflet with a huge jet of tricuspid regurgitation with a reflow of in the suprahepatic veins. So no doubt that this is a severe tricuspid regurgitation. Now, those are patients who entered in our study about atrial fibrillation. So here we have the 3D recordings showing a very large regurgitation, anatomical regurgitation orifice that you can see here, and that we can quantify in 0.8 centimeters square. No doubt that this is severe tricuspid regurgitation. Also, we use the 3D to measure the right ventricle and the right atrium volumes, and also assess the function of the right ventricle using the 2D speckled tracking. And finally, we used this new software provided by GE to make a quantitative assessment of the tricuspid annulus and also of the tenting of the leaflets to better understand the mechanism of tricuspid regurgitation. So this is a patient already in a sinus rhythm with this severe tricuspid regurgitation, and she's symptomatic for heart failure. So the question is how to manage this type of patient. And for some reason, the patient was out of our list also due to the COVID. And so after a few months, she came back to the echo follow-up. And once again, we see the remodeling of the left atrium. And what was a torrential tricuspid regurgitation was just a trace of tricuspid regurgitation with no reflow in the suprahepatic veins. And once again, we measured the right ventricle, we assessed the function, we measure also the right atrium and the tricuspid annulus to provide a more meaningful comparison now using 3D echocardiography. And you see that looking at the volumes, we have just small changes, an improvement in the function of the right ventricle as usual, but the myocardial function assessed with the strain didn't change, pulmonary pressure didn't change, and once again, what was the most striking change in this patient was the volume of the right atrium that almost halved with a big change in tricuspid annulus area and also in the tricuspid annulus diameter. So these two cases are clearly in conflict with the concept that is the right ventricle that is driving the change, the etiology of tricuspid regurgitation. And we have postulated the fact that the atrium is the major player in patients with atrial fibrillation of the onset of tricuspid regurgitation in this recent paper published on a case where we were able to use 3D echocardiography to measure the size and the function of the right atrium, of the right ventricle, to look at the leaflet of the tricuspid valve, and also to quantitate the annulus. And then we started a prospective study where we put together the 3D technology to better understand the pathophysiology of tricuspid regurgitation in atrial fibrillation. This has been recently published in the European Heart Journal Cardiovascular Imaging, a quite large study population, including healthy volunteers, patients with pulmonary, just post-capillary and pre-capillary pulmonary hypertension, congenital heart disease with severe pulmonary regurgitation, and also atrial fibrillation patients. And what we found is that the correlation between the tricuspid annulus area with the right ventricular volume in the overall study population was significant but not so strong, but the relationship between the tricuspid annulus area with the right atrial volume was much stronger. So it seems that there is more a relationship with the size of the right atrium than the size of the right ventricle. And this is exemplified in this figure. On the left, you have the normal size of the right atrium, the normal size of the tricuspid, the tenting of the tricuspid, the normal annulus area, and the normal right atrial volume. And you see that in the patients with pulmonary regurgitation after repair of the tricuspid, of the tetralogy of Fallot, you have the largest right volume, but the you have also the smallest of the right atrium, and the annulus is not so dilated, and you don't have a tenting of the valve. In patients with pulmonary hypertension, you have a moderately enlarged annulus, but what is important is the tenting of the leaflet, and there is an enlargement of the right ventricle, but it is not that big, and also a mildly enlarged right atrium. As opposite to the tetralogy of Fallot patients, you have a patient with atrial fibrillation where the largest atrium but the smallest ventricle, and they are the patients with the largest tricuspid annuli with almost no tenting. This was also justified by our anatomist, showing that in the composition of the tricuspid annulus, that as you know is mostly virtual because there is no fibrous tissue except for the septal part, mostly is just fat, and you see here a transversal cut with the right coronary artery, and you see that in the tricuspid annulus the muscle fibers arrived from the right atrium but not from the right ventricle, that are stopped at the hinge point with the tricuspid leaflets. The same, almost similar findings were already reported by Utsunomiya and co-workers from Los Angeles, that showed that in patients with atrial fibrillation, the area of the annulus is the largest compared with the patients with left heart pulmonary hypertension or in controls. This was also consistent with the known epidemiology, because the atrial fibrillation is highly prevalent in all types of functional tricuspid regurgitation, but the question so far was if it is the tricuspid regurgitation that starts the atrial fibrillation or the reverse. We know also that in patients with atrial fibrillation, it has a negative impact on morbidity and mortality on those patients. So we recently developed this idea that there are two different pathophysiology of tricuspid regurgitation. On one end of the spectrum, there are patients who have no remodeling of the right ventricle, but mostly the dilation of the right atrium. And so the mechanism is mainly due to the dilation of the tricuspid annulus with no or very small tethering of the leaflet. On the other end of the spectrum are patients with pulmonary hypertension, where is a huge remodeling of the right ventricle with the repositioning and the reorientation of the papillary muscles. And here the main mechanism is the tethering of the leaflet with less dilation of the annulus. And then, of course, there are many cases that are just in between. So recently, Denisa Muraro and co-workers put together this concept that in the etiology of atrial of functional tricuspid regurgitation, we have two main forms: the atrial form, that in patients with atrial fibrillation, with mainly dilation of the atrium and the annulus, very small tenting, that as opposite to the ventricular functional tricuspid regurgitation typical of patients with pulmonary hypertension, either pre or post capillary, with smaller annular dilatation and much higher tenting volume. And this was also confirmed in our most recent research by Andrada Guda and co-worker, that is in press on Journal American Society of Echocardiography. Again, extensive use of 3D to make a meaningful quantitation of all the components of the functional tricuspid regurgitation, right ventricle, right atrium, and the tricuspid annulus, to show that the main determinant is not the maximum volume of the right atrium, but just the minimum volume of the right atrium. You see here that if we separate patients with severe functional tricuspid regurgitation in green, mild tricuspid regurgitation in blue, and moderate tricuspid regurgitation in red, you see that more severe is the tricuspid regurgitation, largest is the minimum volume of the right atrium. And this makes a lot of sense because if we correlate the largest tricuspid annulus area, that is the one occurring in end diastole, this is following the same path as we have seen for the right atrium. So there is a close link between the right atrium size and the severity of tricuspid regurgitation. So we go for a reshape of the pathophysiology of a functional tricuspid regurgitation. I don't want to go through this very complex scheme, but just to show you the central place that now the right atrium has in this scheme as the main determinant of functional tricuspid regurgitation in a patient with atrial fibrillation, mainly due to the tricuspid annulus dilation, as we have shown, while the right ventricular dilatation of dysfunction is mainly linked to patient with the pulmonary hypertension in either way it comes, and in those patients the mechanism is mostly linked to tricuspid leaflet tethering. So just to conclude that the right atrial volume and function is a previously unrecognized main determinant of tricuspid annulus size, and the atrial fibrillation to the right atrial dilation are highly prevalent causes of tricuspid regurgitation. And the increased incidence of atrial fibrillation with the aging may also explain the observed increased prevalence of tricuspid regurgitation with age. And our results have important management implication, because more than just the rate control, we can reduce the burden of functional tricuspid regurgitation by aiming to restore the sinus rhythm, being aggressive of restoring the sinus rhythm in those patients. Thank you very much for your kind invitation.
Thank you, my professor, Dr. Luigi, for this elegant lecture. Please, I want to ask you, do you have in Italy, in Padova or Milan or whatever, any experience about the procedure, new procedure of transcatheter tricuspid valve repair in Italy?
Yeah, this is the new frontier in the treatment of patients with functional tricuspid regurgitation that are not deemed for surgery. It's a starting experience. We started in Padua to treat those patients in such a way, and we have not yet implemented here in Milan. So I have just a limited experience of, I think, 10, 20 cases that I monitored when I was in Padua. A few of them with the valve implant, with the navigate device, and most of them with the mitral clip adapted to the tricuspid valve.
Yeah. Any question?
Thank you, Professor. It's such an amazing presentation as usual. And you know, in one study, it was shown that the AF to right side was around 9%, whereas for the left side, heart disease around 40%. And you outlined very nicely how the 3D echo can precisely diagnose the etiology of tricuspid triggers. This is my first comment. My second comment: how can you overcome the stitching defects noted in these patients with atrial fibrillation?
Okay, I will start with the second question. That is a very important one. You know that the last generation of 3D ecosystem have the single bit full volume acquisition that can reach enough frame rate. And when you reach a frame rate around 20 volumes per second, you can make a quantitation. However, I have also to say that in our patients with atrial fibrillation, 75% of them, we were able to obtain a multi-bit acquisition. This is not easy, but not all atrial fibrillation are so irregular. And so if you reduce the number of bits to acquire to 3 to 4, and you have the patience and the commitment to wait, you always find 3 to 4 beads that are close enough to provide full volume data sets without stitching artifacts. And we were able to do it in almost 75% of the patients that are included in the last paper that I presented from Guta and co-workers.
Okay, thank you, Professor Luigi Badaro. We have the honor to have you as a best teacher of 3D echo all over the world, number one. We want to see you here in Egypt in the future, in Luxor or Cairo, whatever. We hope to see you.
It would be my honor to come to Luxor. I went once in my life, but I wanted to come again to visit such a wonderful place and to meet the Egyptian colleagues to share the 3D experience.
Thank you very much, Prof. Thank you. Thank you. Thank you.
Hi, Dr. Randa.
Good morning.
Good morning.
Good morning.
Just a minute, just a minute, just a minute.
Hi, I'm Dr. Muna Naim, and I'm happy to introduce you here in CardioLuxor. You are eminent professor in cardiology, and I'm happy to introduce you here with us. Dr. Randa is Randa Tabba, is a Lebanese, and she will speak from England. Yeah?
From Lebanon.
From Lebanon, hi.
Yes.
And she will speak about the role of 3D echo in mitral clip procedure. You are welcome, and you have to start with us, please.
Thank you. Thank you so much for inviting me to this amazing event. I'm gonna try to share my screen now. So we're gonna discuss today the role of 3D echo in mitral clip procedures. So first of all, as you all know, the mitral valve is a very complex valve with a very complex anatomy. So to have an optimal intervention, we need to have optimal imaging. As you know, the mitral valve anatomy, we have the anterior annulus, the posterior annulus, the chordae tendineae, the anterior and posterior leaflet, and the lateral and medial papillary muscle. And if you see here, the leaflets are normally asymmetrical. The anterior leaflet has a large surface area, but it occupies a smaller amount of the annular circumference. So some landmarks to see, we have the anterior leaflet, the posterior leaflet, and the anterior leaflet is proximal to the aorta, and lateral we have the left atrial appendage. So to evaluate the mitral valve, we have several imaging. We can use the 2D echo with several angles. We can use the 3D echo, and we can use the geometrical imaging. So first, echocardiography is an essential imaging modality for mitral clip treatment. We're going to talk about the patient selection, the guidance of the procedure, the identification as well as the assessment of the complication, the evaluation of the final result after clip, and the assessment and follow-up of mitral regurgitation. First, the patient selection. We need to select patients with moderate to severe MR that are not suitable for surgery. Several parameters for the quantification of mitral regurgitation, quantification of the mitral valve annulus, measurements of the leaflets, measurements of the tenting, of course, the vena contracta area and the PISA for the measurement of the effective regurgitant orifice area. A vena contracta of more than 0.7 centimeter with a systolic flow reversal with the E wave dominant in the mitral valve inflow, an effective regurgitant orifice area more than 0.5 are all signs of a severe mitral regurgitation. So first of all, we need to localize our etiology. And to localize our etiology, we need 2D echo, but also it is important to assess with 3D echo. First, if you look here, with the mid-esophageal 4-chamber view, we can see here the aorta and we can see A1, P1. When you go more deeper in the esophagus, you can see A2, P2. And when you go more deeper and posteriorly, you can see A3, P3. With the intercommissural view, you can see the scallops P1, P3, and A2. And with the LVOT view, you can see A2, P2. But all of that, it's not enough. We need to have a more detailed identification of our scallops. And for that, we're gonna use the 3D echo. We have more views and better identification of all scallops. And here we can see the most common used view, which is the surgeon view with the all scallops identification. So we're gonna discuss the morphology of the mitral valve and the suitability for mitral clip. First of all, the MR mechanism could be primary due to a degenerative problem, of course, like in prolapse or like in Barlow disease, and it could be secondary or functional, like in inferior MI or in patients with dilated cardiomyopathy and tethering of the valves. Okay, so some anatomical measurements. In case of a degenerative mitral regurgitation, we need to measure the flail gap and the flail width. The flail gap is measured on the left, on the 4th chamber and 5th chamber, and the flail width is measured on the transgastric short axis view. For the functional mitral regurgitation, coaptation is important, so we need to measure the coaptation length and the coaptation depth, and it is on the 4th chamber view. Here it is a case of a degenerative mitral valve. If you see here, we have a prolapsed P2, but if we look further with the 3D echo, we can see here an involvement also of both P1 and P2. And the geometrical model of the mitral valve will help us to see an involvement of P1 and P2. Okay, this is the case of a functional mitral regurgitation. We have a tethering of A2, P2, and if you look more for the 3D echo, you will see that the tethering is not only for A2, P2, it is A2, P2 and A3, P3 with an incomplete coaptation here. And if you look further for the geometric models, we have a tethering of all scallops below the annulus, the mitral annulus. So potentially the mechanism of secondary mitral regurgitation, it is due to several things. First, the LV distortion, papillary muscle displacement, and annular dilatation, which all causes a tethered chordae and incomplete mitral leaflet closure. The tethering could be symmetrical and asymmetrical. Asymmetrical in case of inferior MI and symmetrical in case of non-ischemic MI. Now we're gonna talk about the ideal valve for mitral clip. The ideal valve for mitral clip is an MR with a central origination, mostly from A2, P2, no severe calcification in the grasping area, the posterior mitral leaflet has to be long enough to allow secure capturing by the clip, and in case of a degenerative case, no excessive flail width or excessive flail gap. So the recommended criteria, as we said, moderate to severe mitral regurgitation pathology in A2 and B2. The coaptation length has to be more than 2 millimeters. The coaptation depth has to be less than 11 millimeter, and the flail gap less than 10 millimeter, the width less than 15. And of course, pay attention on the mitral valve orifice area that has to be more than 5 centimeters, so to reduce the risk of possible mitral stenosis when adding a clip. And don't forget the length of the posterior leaflet that has to be long enough, more than 10 millimeter in these cases. In case of an unsuitable mitral valve morphology, it is we have perforated mitral leaflets or clefts, severe calcification in the grasping area, a length of the posterior leaflet that is less than 7 millimeter, and in case of rheumatic disease with restriction in both systole and diastole. Here we can see the assessment of a flail gap, 6 millimeter, that is less than 10 millimeter, which is mostly suitable for mitral clip. And here we can see the measurement of the posterior length of the leaflet. We have some intermediate suitability, and this is in patients with a pathology of A1P1 and or A3P3, and with a mitral valve area between 3 and 4 centimeters square, and the posterior leaflet length between 7 and 10 millimeter, and possible leaflet restriction, but only in systole, in both systole and diastole. So using 3D echo before our procedure in mitral clip, we will benefit from the orthogonal view, from detailed mitral valve anatomy and function, from scallop identification and identification of clefts, gaps, and perforation, and also the visualization of the mitral annulus. Now we're gonna go for the steps of the procedure. 3D echo is very important in the procedure to help us visualize more the delivery catheter wires and devices, and to help us in positioning of the mitral clip perpendicular to the line and of coaptation, and also reduction in the procedural time. So first, the transcendental puncture. It is the most important aspect in the mitral clip procedures. The optimal puncture site is located in the superiorly and posteriorly, whereas, for example, in the left atrial appendage closure, it is inferiorly and posteriorly. How are we gonna assess the planes so we can see and we can have an idea of the optimal site? If you see here, we have the bicaval view with the landmarks of the superior and inferior vena cava. So we can here you see the superior landmark. And yet when you go to the short axis view with the anterior, which is very proximal to the aorta, and here we have the posterior one, so it is superiorly and posteriorly. And don't forget about the 4-chamber view with the transeptal puncture and the tenting from the puncture towards above the mitral annulus. This measurement, this height, has to be more than 4 to 5 centimeter in case of a degenerative mitral regurgitation, and 3.5 centimeter in case of a functional mitral regurgitation. PFO and ASD should be avoided because the problem of PFO and ASD, we will not have a very good stability of the delivery system of the clip in these cases. Then we have the introduction of the steerable guiding catheter. As you see here in 3D, we can use several views, the long axis, the commissural view, and the 3D view, the surgeon view. When you go and advance your clip, the clip system, delivery system into the left atrium, if you see here, the use of 3D echo is very important to reduce the risk of left atrial wall injury, and also to reduce the risk to go into the left atrial appendage and cause a lot of thrombus. Also with 3D echo, you have to use fluoroscopy to have a better knowledge of your positioning. Okay, so this is the guidance of the interventional catheter and advancement in the left atrium. And the steering and positioning of the mitral valve, of the mitral clip above the mitral valve, it is very important to adjust medially and laterally using the intercommissural view, and the adjustment anteriorly and posteriorly with the LVOT view, and be aware that no clip arms should be seen in the intercommissural view. And of course, the use of a single 3D en face view is very important. As you see here, the alignment of the clip arm to the coaptation line, it has to be a perpendicular alignment. We can see here in the 3D. And also then advancing the mitral clip into the left ventricle. Be aware that the arm has to be closed. Then when passing, we will reopen the arm below the coaptation of the leaflets. Using the LVOT view, it's better for A2P2, and the intercommissural view, it's better when we have a problem of A1P1 or A3P3. When grasping the leaflets, 3D echo has no clear benefit in this part of the procedure, but the insertion of the posterior leaflet is commonly best seen with the LVOT view, and the insertion of the anterior leaflet is best seen in the 4-chamber view. Then we have here the grasping of A2P2, and finally we will have the famous typical double orifice mitral valve opening. Then we did the grasping. Now we're gonna test the gradient. To test the gradient, it is important to have a gradient that is less than 5 millimeter mercury. If you have more than 5, it is better to stop the procedure because you will risk to have a mitral stenosis in this case. And planimetry of both orifices is ideally done with 3D TEE and alternatively done with 2D TEE. Then final color check and release of the clip. So we need to assess the grade of the regurgitation, the stenosis of the mitral valve, and of course the complication. Be aware that post-clip quantitative Doppler evaluation is problematic due to multiple jet orifices, and there is overestimation of residual MR in patients with multiple jet. The final look, we need to assess the clip location from the left atrial view and from the left ventricle view. Here we can see the grasping, and finally you can see the double orifice mitral valve opening. So here also the double orifice mitral valve opening from the left atrial side, and from the LV side you can see the clip. We need also to assess the pulmonary vein estimation. The regurgitant volume could be also calculated, and the 3D acquisitions of the LV volume. PISA here is not so validated for multiple mitral regurgitation jets, but the measurement of vena contracta area in 3D echo has shown some potential for the quantification of MR with irregularly shaped vena contracta area, mostly in patients with a functional mitral regurgitation. Here you can see a reversal flow of a reversal systolic flow of the pulmonary veins, and after post-mitral clip, we will see a normalization of the systolic flow. And don't forget also about the iatrogenic atrial septal defect, and we need to check it after the procedure. And if the patient has severe RV dysfunction or high pulmonary pressure, we need to think about an SD closure in these cases. So fluoroscopy is more helpful than TE in positioning your second clip. It should be aligned as parallel as possible to the first clip, and for residual MR, more clips may be deployed. Here you can see we do the measurements of the area. And finally, the possible complications. I'm not going to detail them all, but we have possible partial or total leaflet detachment and possible mobile thrombosis. And post-procedural follow-up, you have to use the color flow Doppler of the mitral regurgitation, the MV inflow gradient, the assessment, of course, of the pulmonary veins, and the residual ASD evaluation, pulmonary artery pressure, the LV size, and LV ejection fraction. The role of 3D echo in assessing MR severity is very important. Major advantage in assessing the vena contracta area, which is non-circular, especially in functional mitral regurgitation. The vena contracta should be used as a post-processing step with 3D orthogonal view, and it has a better correlation with the effective regurgitant orifice area. So as a conclusion, 3D echo is evolving fast. It is an important tool for the diagnosis of mitral valve pathology, and it plays an important role in the management of patients and guiding transcatheter treatment. And in the near future, it will replace the conventional 2D echocardiography in mitral valve assessment. And to end my session, I'm going to say something that Carpentier once said about the mitral valve. It is somehow like a woman. More you try to understand and less you will understand. And thank you.
Thank you, Dr. Randa, for this eminent lecture. Really, you answered all of my questions about the procedure of mitral clip, and also about the role of 3D echo, especially transesophageal echo, in the procedure of mitral valve clip and assessment of the anatomy and everything about mitral valve before intraoperative, after also the procedure. And so thank you very much. And if there is any question.
I have one comment. Do you think that the 3D echo will really will be the common practice and the conventional practice for cardiology or for echocardiography in the near future? Will that you think it will be cost effective to replace totally the conventional 2D?
I think it is very important. It helps us to have a lot more information about valvular disease and everything. But in conventional use, it is very difficult to use 3D echo for all patients. You need to have a lot of good imaging. We don't have good imaging in all patients, especially with transthoracic echo, for example. But it has a lot of potential, and it will help us a lot in the near future.
Yes, thank you very much. I agree with you, but of course, it is. We thought in the few years that it's just a form of pretty pictures giving to the clinician, though through the years it become an integral part of a focused examination for the echocardiography. So I agree with you, and particularly for the mitral valve, it will be very highly beneficial. Thank you very much. It was just an amazing presentation. Thank you.
Hope to see you in the next year in CardioLuxor, inshallah.
Hope so, and thank you so much for your invitation.
Thank you. Thank you.
Okay, I'm Dr. Negla Mukhtar. It's my pleasure to introduce our next speaker, Mr. Muhammad Rashad, and his interesting title is the Unmasking the Function of Hidden Cardiac Chamber by 3D Echocardiography. And actually, I want to ask my interesting that's what is the hidden cardiac chamber? So I'm waiting your lecture, Mr. Dr. Muhammad.
Okay, good morning, everyone. I'm Dr. Muhammad Rashad, lecturer of cardiology at Cardiology Department and Chance University. I would like to thank all the chairpersons for these fruitful and informative sessions regarding the 3D echocardiography, and I'm going to answer your questions regarding the hidden cardiac chamber. We all know before starting our presentation that the hidden cardiac chamber, which not most of us, but usually it's missed in during our routine study, which is the right ventricle. Okay, and we are going to address how to use the 3D echocardiography for the assessment of this hidden cardiac chamber. But first of all, I would like to handle our agenda today, which we will talk about the right ventricular anatomy, the right ventricular physiology, the qualitative and quantitative assessment for the right ventricle by 2D conventional methods, and the right ventricular assessment by 3D echocardiography. We will talk in details about the stepwise approach for the assessment of the 3D, because it's the main topic today in our workshop, and how to use it clinically and apply it during our clinical practice. Okay, I would like to give a small hint about the right ventricular anatomy and the physiology in order to show the importance and the contribution of the right ventricle in the overall cardiac function. As we all know, that the right ventricular anatomy is not only formed of the inflow portion and the body, but it's formed also of the outflow portion or the infundibular portion. And these portions are actually formed of fibers arranged differently from each other. The inflow portion of the right ventricle is mainly composed of two types of fibers oriented differently, circumferential fibers in the subepicardium and the longitudinal fibers in the subendocardium. However, the outflow portion are formed mainly of longitudinal fibers, and it's overlaid by spiraling muscle fibers which run at right angle to the long axis of the right ventricle, serving to bind both ventricles together. Because of orientation of the right ventricular fibers, the global assessment of the right ventricle is very difficult. We have two main sections acting or contracting perpendicular to each other: the inflow portion longitudinal and outflow portion circumferential. Regarding the right ventricular physiology, as we all know that the right ventricle and the left ventricle are two distinct cardiac chambers that are anatomically bound in different ways or in a number of ways. They sharing the same blood supply or overlapping blood supply. They share spiraling muscle fibers, as we said before. They share interventricular septum, and both of them are bound by pericardium within the intrathoracic cavity. So, in this unity, the function of one ventricle will necessarily affect the other. And we have a dramatic example for this, the right ventricular infarction in patients with inferior STEMI. As we all know that the LV function is totally preserved. However, the cardiac output decreased in these patients due to the right ventricular dysfunction or the impairment of the right ventricular function. How about the qualitative and quantitative assessment of the right ventricle by the conventional methods? We all know about this, that we can qualify or we can assess the right ventricles not only from one view, but we have different views. And this is actually a main obstacle for assessment of the function of the right ventricle by the 2D echocardiography. If you wanted to see about the views of where we can assess the right ventricle, as we can see here in the parasternal long axis view, we can assess the anterior wall of the right ventricular outflow tract. While in the parasternal long axis inflow view, we can assess the anterior and the inferior wall of the right ventricle. While in the short axis, parasternal short axis view, at the level of base, we can assess here the inferior wall, the lateral, and the anterior wall. In the subcostal view, we can assess the inferior wall of the right ventricle, and in the apical fourth chamber view, we can assess the lateral wall of the right ventricle. So actually, we don't have one single views for assessment of the right ventricle, we have multiple views. Regarding the quantitative assessment of the right ventricle, as we all know that we can use the transannular plan systolic excursion for assessment of the right ventricular function, and also we can use the Doppler methods for assessment of the right ventricular performance, of the right ventricular myocardial performance index. And at the same time, we can use what is not most reliable, but we can use it during our 2D conventional studies, a fractional area change, by assessing the difference in the area between the diastole and systole of the right ventricle, and also the rate of pressure increase of the right ventricle by assessing the time required of the tricuspid regurgitant jet to increase velocity from 1 to 2 meters per second, and it will be abnormal if it is less than 400 millimeter mercury per second. So, as we all see that, all of these measurements, all of these parameters are assessed by 2D echocardiography, but all of them entailed only the inflow portion. So how about the outflow portion? It's totally missed. So, as we said, there is a variety of two-dimensional echocardiography measurements and Doppler parameters have been described for assessment of RV dimensions and function. But none of them so far has demonstrated superiority over cardiac catheterization or cardiac magnetic resonance MRI for the following challenges: the complex asymmetrical geometry, the severely trabeculated inner contour with a poor endocardial delineation, and separate inflow and outflow, which may be adequately visualized only from multiple and separate views, and the load dependency and the lower accuracy of most conventional echo parameters in comparison with the invasive measures. So we resort to the cardiac MRI, which is now the most reliable non-invasive tool for this purpose. And mostly due to its unique spatial resolution and the 3D imaging capacity, we started to use it more for the assessment of the right ventricle. However, we still have challenges for the cardiac MRI, including sometimes it's not applicable in some patients with implanted metallic devices or the patients who has claustrophobia, and at the same time, the high cost, the long time for scan, the limited availability, and limited ability to assess load-independent parameters such as myocardial contractility. So as a result of the cons we have from the 2D conventional measurements, and at the same time from the challenges facing the cardiac MRI, we have to resort to the 3D assessment in order to trying to combine the pros of both the 2D and the cardiac MRI. The 3D assessment of the forgotten chamber, the right ventricle. We have here in Egypt a dedicated software for the right ventricular assessment of the volumes and the functions, and it is organized by TomTech software for the proper quantification. However, some studies, as we know, have been published by Anwar et al. In 2012, he used the QLab for quantification of the right ventricle instead of the left ventricle. But actually, the only dedicated software for the right ventricle was invented by the TomTech for the proper quantification. What is the stepwise approach for assessment of the right ventricle by the 3D? First of all, it depends on two important points: the proper selection of the patient and the proper ECG gating. The proper selection of the patients, because you have to acquire a proper 2D image. The main pillar for 3D acquisitions of volumes and function is obtaining a proper 2D images, okay? Number two, the patient must be cooperative, because you give an instruction for the patient to obtain multiple beats while he holding his breath. And number three is about the proper ECG gating in order to avoid the stitching artifacts. And at the same time, if you have atrial fibrillation, as the previous session said, we can decrease the number of beats acquired to avoid the stitching artifacts during atrial fibrillation acquisition. As we see here, we have a patient for assessment of, sorry. Okay, so we have a patient here for assessment of the right ventricle, and we try to use the RV focus view and assessing the right ventricle by using the 4V probe. We started to give a patient an instruction to hold his breath until counting to 6 or 7, and started to acquire the volumes by 3D. It is divided here. We're using what's called the bi-multi-slice technique for assessment of the RV volumes, and it's the most reliable technique for the assessment of the right ventricle, better than what's called the bi-flex slice or the real-time 3D. So during acquisition of the 3D volumes, the patient actually took his breath, and unfortunately we have stitching artifacts as seen here, and these stitching artifacts will result in false outcomes during assessment of the right ventricular volume, so we have to avoid it, okay? Let us see here in the next patient. Okay, so this is another patient here with pulmonary hypertension, due to anomalous pulmonary venous drainage, we started to acquire the 3D volumes by using a multi-slice technique, and actually we obtained it without stitching artifacts. And then we started to move through stepwise approach, which is available by this dedicated software for the right ventricular volume acquisition. First, after acquisition, offline analysis, after acquisition, we started the processing for the offline analysis. We have, first of all, to align our right ventricular volumes across the longitudinal and the transverse axis by aligning the tricuspid valve center and also at the apex, trying to move it to be perpendicular towards these lines. And at the same here in the sagittal views, we're trying to adjust it as much as we can. And then we started to define the borders of the right ventricle, the tricuspid valve free wall and the tricuspid valve septum and the apex, in addition to the right ventricular and the left ventricular insertion point anterior and posterior and the right ventricular free wall. All of these data are required for delineating the inner borders of the right ventricle. And then we do what's called by fine adjustment for the inner borders of the right ventricle here in the end diastole frames and here in the end systole frames. We start to adjust it here in the apical four-chamber view and in the sagittal view in order to delineate properly the inner border of the right ventricle in the different portions. And also we can rotate this line either clockwise or anti-clockwise to get the coronal views of the right ventricle and to get the outer portion of the right ventricle to delineate properly this green line for a proper assessment of all of the three portions of the right ventricle. As we can see here, the outflow portion appeared during rotating from the clockwise and anti-clockwise, and going from downwards to upwards, we can move from the base to the apex to delineate more the green line to define the inner border of the right ventricle. After all of these informations, and we give it to the software, we process the 3D reconstruction of the right ventricle in the next step. As it appeared here, by using 4D O2RV quantification, we have the 3D reconstruction model for the right ventricle, and all of this information are 3D acquired regarding the end diastolic volume, the end systolic volume, the 3D ejection fraction of the right ventricle, also the TAPSE and the fraction area change can be calculated through the 3D assessment for the right ventricle. And also we can we can define which is, if it is a proper assessment or not through these graphs by applying the volumes across the cardiac cycle of the right ventricle. As we've seen here in the end diastole, we go downwards and in systole goes upwards through increasing of the volumes. And this can give us an indicator whether what we lined before during the inner border of, within the inner border of the right ventricle is true or not. So, what's the clinical applications of acquiring 3D reconstruction model of the right ventricle? Now, the terms are different, okay? We don't have just only the right ventricular free wall and the tricuspid valve and the body and the outflow portion. We have two different surfaces for the right ventricle by the 3D. The septal surface and the right ventricular free wall surface. And each of these surfaces is divided into four portions: the outflow portion, the body, the apex, and the inflow portion. This is for a proper assessment of every portion of the right ventricle, which cannot be done by the conventional 2D echocardiography. As we said in the previous slide, that we can get the 3D ejection fraction by applying these methods of the right ventricular volumes and the right ventricular ejection fraction, and we have different articles into this portion of the ejection fraction. Lastly, it was published in 2013 regarding that the end diastolic volume, the normal values is about 95 plus or minus 20, and about the end systolic volume, which is about 36 plus or minus 11, and regarding the ejection fraction of the right ventricle, 63 plus or minus 7. These are the normal values. However, still, limited data is available about these values. No guidelines is ascertained for these values, and it's different from one population to another. That's why in our department, we started to conduct a study, including the normal values for the ejection fraction and the right ventricular volumes by the 3D for the Egyptian population to get the the most accurate numerical values for these parameters. Moreover, we can use, as said by Professor Luigi regarding the tricuspid valve annulus, we can use the flex slice method for the tricuspid valve, for assessment of the tricuspid valve, and also there is a dedicated software for assessment of the tricuspid valve for assessing the tricuspid annulus, the area, and the tricuspid valve tenting volume, in order to determine the longest dimensions and the shortest dimension, and to get a proper assessment for the tricuspid annulus area, and also to get a proper assessment for the tricuspid valve tenting volume. And here also we can use the flex slice to assess the tricuspid valve tenting volume. This is only by using the 3D flex slice, but there is a dedicated software for these measurements. We can get directly by applying the same previous steps, but on the tricuspid area, on the tricuspid valve, we can get the tricuspid annulus area and the tricuspid valve tenting volume. And actually, as we said before, that these parameters are essential for the cardiothoracic surgeon to determine what's the underlying mechanism for the tricuspid regurgitation, whether it's due to tethering of the papillary muscles or due to dilatation of the tricuspid annulus area. Because in patients with a pulmonary hypertension, mainly the underlying mechanism is increase the tension of the papillary muscles, which lead to increase of the tricuspid valve tenting area, and not due to the tricuspid annulus dilatation. So as a result, if just only tricuspid valve repairs through a ring, in the patient with pulmonary hypertension, this will not rectify the tricuspid regurgitation. So about the 3D reconstruction models, as seen here, this is a patient with a normal pulmonary artery pressure and with a normal RV function. And this is the normal shape for the 3D reconstruction model. Here from the septal surface, this septal surface is concave, while in patient with a pulmonary hypertension and right ventricular dilatation and the impairment of function, this septal surface started to be more convex, to be flattened and then more convex. And this actually was used by was published in the European Heart Journal in 2016, trying to define the degrees of changing from a concave surface to a convex surface during following up of the patient of pulmonary hypertension. This finding actually very helpful for early detection of the right ventricular failure during the follow-up of patient with pulmonary hypertension or any volume or pressure overload of the right ventricle, because early detection of a change of the concavity of the septal surface of the right ventricle will give us a hint that the right ventricular failure started to occur, and this will be more earlier than the 2D conventional methods. Moreover, during the assessment of the 3D reconstruction, the global function of the right ventricle depends on 3 components: the longitudinal shortening, and the radial shortening, and the anteroposterior shortening of the right ventricle. And each pathology affects each of these components separately and earlier before other pathologies. For example, in patients with a pulmonary hypertension, if you are going just to follow the TAPSE of this patient in order to detect the right ventricular failure, unfortunately you will detect it very late after it becomes irreversible, because the main component which is affected in patient of pulmonary hypertension is the radial shortening and not the longitudinal one or the anteroposterior one. So it's very important to define it through the 3D assessment or the 3D reconstruction model of the right ventricle. While in patient with a heart transplantation or a patient post-CABG, the longitudinal one is earlier to be affected, while the radial and the anteroposterior one are totally late to be affected. So it's very important to determine which component is affected earlier for a proper intervention and addressing your medical treatment earlier in this patient. One of these studies is conducted in our department, trying to know the effect of pulmonary hypertension, secondary congenital heart disease on right ventricular volumes and function. We started to compare between the 2D conventional methods and the 3D methods and correlate it with the invasive methods for assessment of the right ventricular volumes and the ejection fraction. Actually, our aim in this study was not only to compare between those parameters, but also to try to get the parameters which can be used non-invasively to predict the pulmonary vascular resistance in patients with reversible pulmonary hypertension due to congenital heart disease. So what we get from this study, that the 3D RV ejection fraction and the tricuspid valve area and the tricuspid valve tenting volume by 3D echo are the most parameters correlated with the pulmonary vascular resistance, which can be used non-invasively to predict the pulmonary vascular resistance if it is more than 7, and to predict whether this patient is suitable for repair or not. But still, we need more population to apply and to verify the equations which we obtained from this study in our cardiology department, and this actually happens nowadays to detect and to get a proper equation for assessment it non-invasively. What is the main limitation? What is the main limitation for using of the 3D echocardiography? As we said before, that's the patient's inability to cooperate for breath holding, number one. Number two is arrhythmia as an atrial fibrillation, but we can do it, or we can handle this problem by decreasing the number of beats acquired during the RV volumes acquisition. Number two is a larger footprint and the size of matrix array transducer, but actually now is available the small one, which can be used even for the pediatric populations, not the large for the probe. Dependence on optimal acoustic quality, need proper 2D images, need for specific training because it's a matter of practice, not just only from 1 or 2 patients, but you have to practice it over 100 patients in order to save your times and trying to use it as during your routine practice. And my take-home message for this presentation that the sonographer should first conduct the echocardiographic examination with regard to the clinical context. You have to search for the clinical and the pathological etiology of the right ventricle to detect what is the method you are going to use for assessment of the volumes and the function. Multiple acoustic windows should be used, and the examination must be based on the integrative approach using both qualitative and quantitative parameters. Not just only one parameter can define the right ventricular function. And of note, a comprehensive examination of the right ventricle may be time consuming, but by practice, you can decrease it just only to about 5 minutes during acquisition of the right ventricular and to get these results rapidly, okay? And finally, still, we have no imaging technique. No single technique is ideal, and still real-time 3D echocardiography makes no exception, but it facilitates it, okay? Thank you.
Thank you, Dr. Muhammad, for these comprehensive lectures.
Yeah, thank you.
Actually, right ventricle was forgotten for a long time, and now it's a spot for interesting for many researchers.
Yes.
You stressed on the shape of the right ventricle.
Yes.
If there is any measurements other like strain, 3D speckle tracking for the right ventricle, did you find? This is my first question. The second, what's time consumed to take this dedicated and from different point of views for the right ventricle in different shape?
Okay, so regarding your first question about if there is a 3D speckle tracking, yes, actually there is a 3D speckle tracking for the right ventricle, but it's not available nowadays in the software here in our country, okay? But it will give us more accurate information regarding the function. It will add more to the 3D assessment and to the 3D reconstruction models. And many articles nowadays are using it for assessment of the right ventricular functions and to correlate it with the other pathologies of the right ventricular impairment. So actually it's present, 3D speckle tracking for the right ventricle. And regarding your second questions about the time consuming for acquisition of the 3D volumes, first, during our start, during acquisition of the 3D volumes, it depends mainly on the cooperative of the patients and the ECG getting these main issues dealing with the acquisition of the volume. So it will take time to adjust this. And after that, just only RV focus view and lining the borders, it will take just about 5 minutes, and all of this will be automatically processing by the software to get the 3D reconstructions and to get all of the information regarding the ejection fraction and the volumes by the 3D. So it's a matter of practice, not only, not more than 5 minutes.
Okay. Thank you,
Thank
Dr.
you.
Muhammad, for this lecture. And I want to ask you, discussed here that there is some limitation in
Yes.
the presence of arrhythmia. I think there is some other limitation because the proximity of the outflow tract of the RV to the sternum, so there may be an echo dropout also in case of severely dilated right ventricle. It is very difficult to obtain a full view for its all walls. This is some limitation of 3D echo in the assessment of RV volume. Also, I want to ask if there is any comparative studies was done about RV volume with CMR or other methodology for the assessment of RV volume? Because I know also that the left ventricular volume is underestimated by 3D echo in comparison with CMR.
Yes, okay. Actually, it's excellent questions about this. Regarding your first question about the shape of the right ventricle and the dilatation and its relation to the sternum. As I said before, and confirming that the 2D image is the main pillar for the 3D acquisition. If we don't get a proper 2D image, actually there is no 3D images. So, as we said before, you have to get a proper 2D study for the right ventricle. And if you get this, you can proceed to the 3D ventricle within a limited period of time. So just only the 2D images are the main pillar, for acquisition of the 3D. If it's polyechogenic, the patient is polyechogenic, we cannot get either 2D or even 3D, okay? And regarding the correlations between the right ventricular volumes by the 3D echocardiography and the cardiac MRI, and this actually were published about maybe in 2003 and started 2007 also. There is a publishing between, there is articles comparison between the cardiac MRI and the right ventricular volumes, and it shows that it mildly underestimates the right ventricular volumes. Yes, it's mildly underestimates the right ventricular volumes, but what's available now is the 3D echocardiography, and what we can use it and overcome the challenges of the cardiac MRI is the 3D echocardiography. So we can use it in a correlation with the cardiac MRI, but putting in mind that it's underestimated the volumes. Yes, that's true.
Okay, our last question from the floor. You can start.
دكتور محمد for this night lecture. هو طبعا انت ابتديت المحاضره وقلت ان هو ان it is a hidden chamber، واحنا كلنا عارفين، احنا بنشتغل ايكو كتير وعارفين ان هو ان دايما كان في قاعده بتقول لك ان الايكو دايما بيظلم الرايت فنتريكل، وهو ده علشان احنا ما do not spend some time ان احنا نكسبلور الرايت فنتريكل، بس هو في بعض البارامترز في ال 2 دي ايكو، انا بتكلم على 2 دي ايكو، ان هو يعني احنا لو الاوبريتور عمل الرايت فنتريكل ايجكشن فريكشن، خد الاند دايستوليك فوليوم، خد الاند سيستوليك فوليوم، خد الام مود بتاع الرايت فنتريكل، وسبند سام تايم ان هو يشوف التريكاسبيد فالف اذا كان في فينا كونتراكتا او يحسب الفينا كونتراكتا، وبعد كده عندنا كذا دوبلر فلو التابسي وتشوف البلمونري، تحاول تقيس البلمونري ارتي بريشر، كل ده حاجات بردك بارامترز بنعملها علشان نشوف الرايت فنتريكل، وممكن ناخد داتا كتير جدا جدا بالذات في الفولو اب، لكن احنا دايما عندنا اقتناع ان هو لو في ترايكاسبيد ريجيرج مش هيتعمل خلاص، يعني الاوبريتور مش هيفتح على الترايكاسبيد فالف زي ما احنا في الانترفنشن الاوبريتور مش هيفتح على الرايت كورونري، فبردك هي دي بردك بتظلم الرايت فنتريكل. انا انتظرت في محاضره حضرتك اما انت قلت ان احنا في بروجرام في ال 3 دي ايكو بيشوف الرايت فنتريكولار اوت فلو تراكت، انت قلت ان هو ال 2 دي بيجيب الانفلو وبيجيب البادي وبيجيب الايبكس، ما بيجيبش الاوت فلو تراك.
بيجيب الاوت فلو تراك
في ال 2 دي في ال 2 دي ال 3 دي قلت ان هو هيجيب، بس هو الاوت فلو تراك اللي حضرتك وريتها صغيره جدا بالنسبه للبادي، يعني احنا لو احنا حسبنا الرايت فنتريكل فوليوم هنلاقي الاوت فلو تراكت صغيره جدا، حتى في الصور اللي حضرتك عملتها في الريكونستراكشن قليله جدا، يعني حتى واضح ان ال 3 دي ايكو لسه شويه ما بيبينش الاوت فلو تراكت. طب ايه اللي هيفيدني؟ طب ما انا ممكن اشوف الاوت فلو تراكت كويس بالدوبلر، وبعدين يعني بالذات اذا كان في فالفولار ابنورماليتي او حاجه زي كده ممكن اشوفها بالدوبلر فلو. يعني انا عايز اعرف هل هو ال 3 دي ايكو it is going ان هو هيجيب لنا الاوت فلو تراكت اكتر بموداليتيز اكتر، ولا هو جاست هي بس ده البروجرام اللي هو هيجيب لنا الجزء من الاوت فلو تراكت مش كل الاوت فلو تراكت؟ ثانك يو.
اوكي بص حضرتك، هو اول حاجه احنا we will never omit the 2D imaging. Okay, we will never omit the 2D assessment for the right ventricle. Okay, Doppler measurements can actually get a proper assessment and can actually get more results regarding the right ventricular assessment. But as we said before, during the 2D imaging or 2D assessment of the right ventricle, you depend only on one component of the right ventricular contraction. You depend only on the longitudinal. Maybe the radial, you can use it during speckle tracking, but regarding the combination of the three components, the longitudinal and the radial and the anteroposterior, it will not get by the 2D. And regarding the outflow portion, okay, you can get it from different views during 2D assessment. But connecting the inflow portion and the outflow portion and to imagine the model of the 3D model of the right ventricle will not be gotten through the 2D. You have to assess through different separate views, as we said, but not from a single view. As here in our acquisition of the 3D volumes, at the end stage or the end step, you get only one model showing the inflow, the body, and the outflow portion. And you can assess the longitudinal, the anteroposterior, and the radial components. You will never get this from one view through 2D assessment, okay? So we're trying to keep it more advanced and to be more easy through assessment of the right ventricle. If you just give me 5 minutes to do the right ventricular assessment through this software, I will get all of the information which you will get through 2D assessment, but consuming more time. That's it.
هو بس يعني هو الاوت فلو تراك، لو الاوت فلو تراك انا محتاج اكتر اشوف بريشر، لو هو مثلا شاكك بالمونري ستينوز او بالمونري جريجيتيشن. الريكونستراكشن حضرتك ايمج اللي عملتها مش مبينه لي اكتر من فوليوم بس، يعني ما ادتناش حتى امبريشن البريشرز اللي موجوده جوه الاوت فلو تراك اخبارها ايه.
Okay, البريشرز will get it through the 2D.
Yes.
So it's an integration between 2D and 3D.
يبقى هنا بقى 2D.
Yes, it's an integration. I said in the last slide that there is no, that's the real-time 3D makes no exceptions. You can use it in integratingly with the 2D, not just alone.
Okay, thank you.
Okay.
Thank you, Dr. Dora. Thank you, Professor.
Okay.
Because of the time.
At last but not least, Dr. Ahmed Farid will take us to the other side of the heart, to the left ventricle. We will talk about the role of the 3D echo in TAVI. تفضل يا دكتور أحمد. دكتور أحمد مدرس في جامعة قناة السويس. تفضل.
Good morning, everybody. I'd like to express my gratitude and thanks for the organizing committee for inviting me to talk about this hot topic. And it's about the role of 3D echocardiography in TAVI. And as we know that TAVI is a procedure where we almost replace the aortic valve by a minimally invasive approach without direct surgical visualization of the valve. And so TAVI has been on occasion been cited as a semi-blind procedure. You don't size the valve directly as we do in surgery. So the accurate determination of the valve size is almost wholly dependent on the robust pre-procedure imaging. So the imaging for determining the size of the valve is crucial for this procedure. The role of echo, we are not here to discuss the role of conventional echo for the assessment of the TAVI. It's well known before the procedure, during the procedure, and the follow-up imaging of a TAVI. But we are here to discuss what the 3D will add to this. As a short review, we can say that the echo for the pre-procedure planning, it helps to confirm the aortic valve morphology and leaflet numbers. It helps in the presence and degree of aortic regurg, mitral regurg, and tricuspid regurg. It helps assess the LV function and RV function pre and post the procedure, and the presence of basal septal hypertrophy and other LVAT obstruction other sites other than the aortic valve itself, and to exclude left atrial, left ventricular thrombus, as this may dislodge during manipulation of the valve during the procedure. But you have specific objectives and specific questions you should answer before sending the patient for TAVI by the echocardiography. You should select the device size, as we said. You should assess the landing zone site. You should assess the atherosclerosis, and the echo help you to guide the valve deployment and assess the peri-procedure complications. And during and post the procedure objective, the echo also come in handy to ensure the proper prosthesis placement, to assess the prosthesis position and function after deployment, assess the ventricular function, identify the immediate post-deployment complications. So what does the 3D echo add to the TAVI and how it plays a role in the TAVI? Because it's a rather of workshop, I would like to make my lecture in a form of 3 big questions I will try to answer. The first question will be, what does it add over 2D echocardiography, and is 3D echocardiography is accurate for the assessment before TAVI, and how to use it in a stepwise approach, as this is a workshop session. Let's start with the first question. What does it add over 2D echocardiography? The first thing is the sizing of the aortic valve or the sizing of the aortic annulus. As we all know, if you use an undersized prosthesis, you will result in a periprosthetic aortic regurgitation, you will have a device migration, you will have a prosthetic patient mismatch, and if you used an oversized prosthesis, you will have an underexpansion with central regurgitation, you will have an annular rupture, and you may have coronary osteal obstruction by the deployed valve itself. So, between having an undersized and oversized, there's something called the Tavi nirvana. And nirvana is the state of clear minding when you have the proper size to put it in place. This is the 3D modeling of the aortic root or the aortic valve itself, and you can see here, it's not just a uniplan thing, it's a 3D construction where you can see that's the points of the leaflets that's hinging on the points of the basal part of the annulus. It's called the virtual ring, and this is actually what you need to measure. As the annulus that is measured by all the imaging technique is the narrowest part of the aortic root, which is called the virtual ring, and the virtual ring with the 3 anchor points at the base of each attachment of the aortic valve leaflets. And despite we have longly been labeled the LVOT or the aortic annulus as being circular, the design of the actual annulus is mostly ovoid rather than spherical. As we can see, we used previously to measure the aortic valve area by using the continuity equation, which depends or assume that the LVOT is a circular. So you use the pi r square to assess the LVOT area, which is not true. And making this more complex, and in Tavi population, as with increasing age and hypertension, the aortic annulus became progressively less spherical and assumes an increasingly elliptical profile, which is most of your patients with increasing age and with aortic stenosis. Also, the LVOT became less distensible and undergoes remodeling in severe aortic stenosis, leading to its increasingly avoidal shape. So we are almost pretty sure that over 3/4 of the patient with aortic stenosis have an ovoid LVOT, not a circular LVOT. And this is not only of critical importance to the imager, but also the implication for the assessment of aortic stenosis severity by the traditional equation, a continuity equation, that they assume the LVOT is circular. So we can conclude here from the previous slides that the aortic annulus is a complex 3D structure. It's mostly elliptical, and any single dimension cannot adequately characterize the annular size. And as a rule, if you want to see something 3D, you have to use the right tools to see the 3D. So you can see here, this is the long axis aortic view represent the shortest diameter of this oval. So what are you seeing or what are you measuring from the 2D is the narrowest diameter. It's not the actual diameter you need to measure. Also, there is some variability of the 2D image, as we all know that the 2D is cutting in a slice. So with just few manipulation of your probe, you may have a wide different diameters of the LVOT with just few manipulations. Also, if you decided to go further and use the X-plan, sometimes the X-plan that use 2 perpendicular views, it's not coaxial. So even if you use the X-plan, you are not pretty sure you are at the tips of the valve itself. So the 3D imaging which more accurately delineate the non-circular anatomy. And we will discuss later in this lecture how to measure this in a stepwise approach. So another very important thing rather than the sizing is the coronary osteal distance. And the coronary osteal distance, you need to measure the distance between the left main ostia to the base of the left coronary cusp, and this is usually not achieved except with the 3D. And also you need to measure the RCA to the right coronary cusp, but you may get this from the 2D. And any measurements below 11 millimeter is considered too small to accommodate the valve expansion without significant risk of coronary osteal occlusion. And you can see from this image here, if your valve is a little bit long or your coronary ostium is a little bit short, you are opening the door and smash the coronary behind you. Also, it helps in the assessment of the atherosclerosis of the thoracic aorta. As you can see here, you have a mobile atheroma in the descending thoracic aorta. You can see it here also. It's a little big wing, but if you add the 3D, you can see it in a more 3-dimensional fashion, and you can assess it more. And how this could affect your decision? It affects the choice of the vascular axis, because in the presence of mobile plaque or thrombi in the descending aorta or the aortic arch, it's a contraindication for the femoral axis, and you may need to shift to the transapical approach for the valve replacement. Also, it assesses the calcification. With the advancement of the aortic stenosis process and all the population of this patient, you may have big chunks of calcium that may affect your decision and may affect the seating of the valve itself later on. As you can see here, there is a chunk of the calcium over the non-coronary sinus view, and with inflation of the valve, you can see how the LE roof is bulging up during this inflation because of this calcium chunk that is moved upward in the left atrium. And during the procedure, the role adding the echocardiography to the fluoroscopy, it decreases the amount of contrast and radiation exposure and help you for the early assessment of the potential intra-procedural or immediate post-procedural complication, and helps you in the correct positioning of the wires and the catheters and guiding of balloon positioning and the visualization of calcium displacement as we had seen before. So let's move on. It's all about the landing zone. You can see the image on the left. You have a steady landing zone, and you have on the right side a very shaky landing zone that may result in a lot of complications. So if you position your valve too low, you may result in a paravalvular aortic regurgitation, you may have an AV nodal impingement, and you may have a mitral apparatus interference with a resulting mitral regurgitation. If you seated your valve too high, you may occlude the coronary ostia, you may have an aortic injury, and you may have a device migration. And this is example how the 3D help you for the proper positioning of the valve. You can see it almost like you are holding the valve in your hand. You moving it up and down until you place it in the right position. You will not be able to do this except if you have a 3D. So the pre-procedure 3D transvaginal echocardiography in combination with fluoroscopy fusion imaging. This is a very recent technique. It's called the Echo Navigator. It also be used to determine the appropriate fluoroscopy plan for valve deployment with minimal or even zero contrast in this approach. What happened is you acquire your 3D image and acquire your fluoroscopy image and put a point in the echo, and it will register this over the fluoroscopy. And the resulting was this marvelous image. It's the fluoroscopy with the echocardiography image over it. And you see the inflation of the valve with the echo image inside. You can see it very clearly. If you go with the fluoroscopy, you will not see it that clear anymore. Also, it helps you in some of during the procedure, the 3D have a relevant importance in this. You can see here, this is an aortic regurgitation that's resulting after deployment of the valve. You can see it after adding the 3D, you can see it clear how much it affects the circumference of the aortic valve, and this is one of the ways to grade the aortic regurgitation after the procedure. And you can see here, it's now a verified method to assess this is the circumference and the extent of the perivalvular regurgitation. And here you can see it with the 3D. It's very clear how much it affects the circumference of the valve, this regurgitation area. And you can see if it is less than 10% of the circumference, it's mild. If it's more than 30%, it will be severe. Also, to avoid the occurrence of the aortic regurg, you have the assumption, and you should avoid it in the first place. These are some risk factors that resulting in aortic regurg, and all of them could be identified by using the 3D echocardiography prior to the valve deployment. If you have a large aortic annulus, if you have an undersized prosthesis, if you have an asymmetric cusp calcification, if you have an LVOT calcification, or you have a low valve deployment, and 3D echocardiography can prevent all of this from happening during the procedure. Let's move on to some of the complications that the 3D have a crucial value. You can see here, the image on the left is prior to the deployment, and image on the right is the after the deployment. You can see here there's a significant mitral regurgitation is appeared after deployment of valve. So what's went wrong? And the operator started, the kid panicked. And here comes the 3D to give you a breeze. It's just the guiding catheter is impinged in the papillary muscles, as this is transcatheter approach. So just he withdrawn the guiding catheter, and then the mitral regurg disappears. So if you don't have the 3D, you will trying to rotate around the valve from different views to just know what's happening on. Another example of this complication, you can see here after deployment of the valve, there is something is playing in the LVOT. What is this? Is this a calcium chunk is moving on? What's this problem? And here also comes a 3D again to give you a breeze. This is the guiding catheter is making a loop within the LVOT itself. So just a retracting of the LVOT make this disappear. So this is the tip of the guiding catheter that you are seeing moving in the LVOT. Let's move on to the second question. Is it accurate? And as we had said, you are trying to see a 3D structure, so you need a 3D modality to see it. So we have a transthoracic, transesophageal, the MDCT and the MRI have been extensively studied with respect to pre-procedural aortic annular sizing, and at present the CT is both more frequently used and more often cited as a gold standard. So if we're trying to compare anything accurate, we will compare it to the CT. As you can see here, this is very close results by tracing the aortic valve area or the annulus measurements using the CT in the images above compared to the 3D in the images below. And we can have here for Jelahawi, that's one of the most important papers about this. You can see here that using the 3D and compared to the CT for the prediction of significant periprosthetic aortic regurgitation and proper sizing of the aortic valve, they are almost comparable. And we have, this is the biggest meta-analysis that had been collected about comparing the 3D echocardiography to the CT. It's including about 5,000 patients. It's concluded that the 3D TE annular measurements, either the annular area, annular parameter, or left ventricular outflow tract area, are strongly correlated to the MDCT, and the inter-observer and intra-observer concordance for annular cross-sectional area and perimeter are high for both techniques. And the MDCT and 3D echocardiography predicted post-Tavi paravalvular aortic regurgitation with similar accuracy. And 3D, this is one of the advantages of the 3D echocardiography. It doesn't require contrast media like what we have in if you plan to perform a CT. And the impairment of the kidney function in these populations, they are old, they have atherosclerosis, it's very common. So this is maybe a very big restriction for using CT in these populations. So, and also, it depends on the level of local experience. So if you are in place with good experience in doing 3D, but no experience in CT, go for the 3D. This is definitely. But if you have a place that's equal in both, you can go for either one, what is available or what makes you more comfortable. So how to use it? This is a step-by-step approach to how to do the annular sizing using the 3D echocardiography. You're starting by optimizing the 2D image in the aortic valve in the long axis view, which is usually in the degree 120 to 140. Always 3D, good 3D images is generated from a good TD images. So if you don't have a good TD images, you will not have a good 3D images. And then you use either the 3D zoom to include the LVOT, the aortic root to sinotubular junction, or you may use the full volume to acquire this set. And then your measurement will be performed on static images thereafter. So you should focus on getting a higher spatial resolution rather than a temporal resolution, and then the 3D images are acquired for post-processing on your commercially available software according to your machine. Now you have your images and you put it on the software. You will have three boxes and then a generated 3D. You will have a sagittal view, coronal view, and transverse view, and then a generated image on the lower right box. You align your sagittal and the coronal planes to bisect the long axis of the aortic valve, and this is very important. You can see here they are not aligned yet, and this after alignment of your axes across the aortic valve. And then you zoom a little bit to be sure that you are perpendicular to the long axis of the aortic valve, and then move to the base of the valve until the leaflets disappear, and this is the narrowest area that you need to measure, and this is the annulus. Okay, then select the transverse plan for this data set, and then you measure the annular diameters, the diameters, the longest and the shortest diameter, and then you need to trace the area to generate this, the annular area by the 3D echocardiography. Another important measurement that you need to measure is measuring the coronary osteal distance, and as we had seen that the left main coronary artery could not be seen or measured except with a 3D image. You move your green box until the ostium of left main appears, and then you move your blue line that's in upper left box until it bisects the left main, and then you start the opening of the left main. Now is very clear, as you can see from the lower left, image with the red arrow. This is the opening of the left main. Now all you need is to measure the distance from the base of the cusp to the opening of the left main. And also for the right coronary, it's a little bit easier. It's higher than the left main, so you measure this from the cusp distance to the opening of the right coronary. Also, you may need to measure the leaflet height because you should know the length of your door that will be Flattened, it will either it will occlude the coronary or not. And also you can do this by the 3D echocardiography. So there are some pitfalls with this if you have dropouts caused by extensive calcification in the LVOT, and this could be eliminated by adjusting each plan to minimize this effect. And always with the advent of new software and the improvement of the software, they tend to do the automation, and the automation will give you more reproducibility and more repeatability with improvement of your results. Okay, so this is example that you just acquire your image and then send it to the software, and the software will do all the measurement for you. This is for the Siemens machines, and also it gives you an idea about the coronary distance, and this is the one generated from the GE machines. It also gives you all the measurements you need, the minimal diameter, the maximum diameter, and the area. So my conclusions here that the 3D echocardiography has a pivotal role in the Tavi procedure. The assessment of the Tavi sizing should be reliably done with 3D transesophageal echocardiography. Per procedure, 3D TE makes the Tavi procedure shorter and more accurate with less complications. The use of the Echo Navigator and the measurements automation made by 3D TE are more reliable and reproducible. And for the pre-TAVR planning in patient with renal dysfunction, 3D TE may be potentially advantageous over CT for TAVR measurements. And I'd like to finish my lecture by looking at this image. This is a real image from a cath lab. They are performing a Tavi, and you can see that all the operators are looking at the echo machine, not the fluoroscopy machine, except only one of them. And this is show you how important the role of the echo is in this procedure. And thank you.
Thank you, Dr. Farid. It was a very informative lecture. You have tackled a very important subject because now the Tavi is everywhere. It's performed in all the centers all across the country, and it has been always a dilemma whether the CT, the MRI, or the echo has a rule, and you proved that the echo is now approaching to replace the CT, particularly in those patients who has high risk and cannot use the dye, and those are the targeted patients actually with the Tavi. Thank you, Dr. Farid. There's a room for a question.
Thank you. Very elegant lecture as usual.
Thank you, Professor.
I think now 3D echo is very enough to evaluate for before Tavi and during Tavi. Then multi-slice CT scan. Multi-slice scan, you cannot use it intraoperative, but 3D echo can use during the procedure to guide it. Also, the measurements before, which was told that it was lower, somewhat lower than the CT, now the same.
Yes.
Recently, they are the same. So 3D echocardiography is #1 in evaluating TAVI procedures.
Yes.
Thank you very much for this. You have another question? Okay, question.
It's not a question, it's just a comment. Thank you for your elegant and comprehensive and clear, dedicated lectures. You go directly to the target. You decided what you want and go target.
Thank you.
You convinced me by 3D echo in Tavi. Thank you.
That's it. Thank you very much.
Thank you, Professor.
Thank you.
We will end this session, and I want to take one word that the idea of this session about 3D echo is by our great professor, Professor Adel Atrebi. He added this session for 3D echo. As 3D echo is, you can never do intraoperative, transcatheter intervention in any valvular disease or ASCD without 3D echo. Because of its importance, he requested to this session. So his great idea of Professor Adel Atrebi. Thank you very much.
I really enjoyed this amazing presentations, and it was just one of the the most prestigious sessions for echocardiography in the last years. And thank you all for the contribution of the speakers from all over the world, from Egypt, from Ain Shams University and South Carolina University, for the chairpersons, for those attendees, and thank you all for, of course, for the CardioLuxor president. This is Dr. Adel Atrebi, and thank you very much. We have to end this session. هتستنيه اسلم